Welcome to the second session in our 5-part Cancer Genetics CME series titled Cancer Genetic Counseling, Guidance for You and Your Patients. My name is Katie Stoll. I am a genetic counselor working with Genetic Support Foundation. I will be presenting and hosting this session today. In this presentation, attendees will learn about what is involved in a typical consultation for genetic counseling and cancer risk assessment. We will review and discuss best practices for ordering genetic testing for hereditary cancer risk. We will also discuss some practicalities about genetic testing, such as cost and navigating insurance coverage guidelines. Lastly, we will discuss shared decision-making and provide tools and resources to help support providers navigate conversations about hereditary cancer risk and genetic testing options with their patients. I'm pleased to introduce our speakers for this session today. Alina Faulkner is a genetic counselor, also working at Genetic Support Foundation. Heidi Holmes is a genetic counselor working with Confluence Health in Chelan, Washington. Dr. Kobe Witten is a psycho-oncology consultant working with Providence Health and Services. Carrie Trout is a breast cancer patient navigator, also working with Providence Health and Services. You can find the full speaker bios and contact information on the Washington Medical Commission website. Continuing medical education credit is available for watching the recording today. If you are watching this in a group setting, please make sure you register for the webinar and complete the evaluation as an individual in order to receive CME credit. The activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Federation of State Medical Boards, the Washington State Department of Health, and the Washington Medical Commission. The Federation for State Medical Boards designates this as an enduring activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in the activity today. The webinar is not funded by any commercial entities, and none of the speakers or planners for this activity have relevant financial relationships to disclose with any ineligible companies. We will not discuss any off-label use or investigational use of medications during this presentation. And with that, I will turn it over to our first speaker, Alina Faulkner. Thank you.
Welcome. Thanks for being here. My name is Alina Faulkner. I'm a licensed and certified genetic counselor, and I'm happy to be a part of this Cancer Genetics CME. So thanks for being here. So in this portion, I'll be talking about genetic counseling, kind of what to expect of a genetic counseling session. And we'll go through a little bit of basics, genetics 101. What is cancer? How does it happen? Why does it happen? Who genetic counselors are, and then we'll kind of get into the meat of cancer genetics and a genetic counseling visit from there. So again, a little bit of kind of back to basics, genetics 101 here. So genetics, of course, is the study of, inheritance, heredity, and how certain qualities and characteristics are passed down from one generation to another by means of, DNA in our genes. Of course, the body is made up of trillions of cells, and inside of each of our cells are our chromosomes. Chromosomes, of course, are the structures that hold our DNA, so tightly wound structures. And DNA, of course, are building blocks of life. So deoxyribonucleic acid, and then within the DNA is our genes. So genes just being individual pieces of the DNA that give our bodies specific instructions of how to grow, function, develop, express certain traits. And we inherit roughly half of our DNA from mom and roughly half of our DNA from dad. Because of this, each piece of our DNA has a copy or a pair. So then a little bit more about, kind of cancer. So cancer is inherently a genetic disease, meaning that it's caused by genetic changes or mutations that happen to our genes that control the way that our cells function, especially how they grow and divide. Cancer currently affects about 1 in 3 folks in the US. There are, of course, many types of cancer, but really 2 main categories in terms of cancer genetics, so solid tumor and then hematologic or blood cancers. And we in genetics, we kind of look at cancer caused by three main reasons or three main categories. So most cancer you'll see there, that big yellow section of the pie, kind of sporadic or random. So most cancer we really think happens because of an accumulation of many different factors over one's lifetime. So factors in our diets, our environments, our lifestyles, kind of stacking up over time. There's also, kind of another category we call familial. So meaning that we think that maybe a combination of multiple genes, but then also multiple kind of shared factors within a family, commonalities within a family, similar diets, similar lifestyles, similar environments, kind of contribute to that, portion of the red portion of the pie there, that familial. And then, of course, is where we have hereditary, so that purple piece of the pie. So about 5 to 10% of all cancers can be kind of genetic or hereditary, meaning that there's a specific gene mutation that's inherited and passed along from generation to generation within the family that can significantly increase the risk for certain cancers or tumors over the lifetime. Again, just highlighting, so most cancer is not genetic due to a strong, risk factor that's significantly increasing the chance. But there are some cancer types that that do have that kind of hereditary single gene mutation that can be inherited and passed along. So breast, ovarian, colorectal, uterine, pancreatic, prostate are some of kind of those common cancers that can have those strong genetic influences. Okay, here's just an example. This graph is kind of representing, again, some of those common cancer types that can have these strong genetic risk factors or gene mutations, again, that can be passed along and inherited within a family. The graph is representing the highest risks associated with some genes in hereditary cancer. So just note that not all genes pose, all of these, these risks. So you'll see again, breast, uterine, ovarian, prostate, pancreatic, colorectal, again, some of those common cancers that can have genetic risk. Okay, so then who am I? Who are genetic counselors? So genetic counselors are healthcare professionals that have advanced training in both medical genetics and counseling. So we really help to guide and support patients through making informed medical decisions when it comes to genetics and genetic testing. Of course, we're here to provide information and resources to patients and their families with genetic conditions. And then, of course, we're also here to interpret genetic test results. We meet with individuals or families before and or after genetic testing, so we can help in either or both, kind of situations. Genetic counselors overall are specialized in many areas of healthcare and serve roles outside of, direct patient-facing care as well. And then we're able to see patients in person and or, of course, with telehealth options these days, especially. So video and telephone as well. Okay, so then specific to cancer genetic counseling. So in a cancer genetic counseling session or meeting, so the genetic counselor helps to identify individuals and families with inherited cancer risk. We can offer proactive and or preventative kind of recommendations for screening and surveillance when it comes to cancer. Determine if genetic testing is warranted for an individual and or who in the family might be best to test, most informative to test. And we'll get to that in a bit. And then also, just to note that hereditary cancer genetic testing can help guide certain cancer treatment plans. So, for example, there's a class of certain agents called PARP inhibitors that might be useful for certain patients in the metastatic setting, especially with prostate cancer. So that's kind of a more recent area of research and coming to the stage in cancer care where genetic results can actually help guide treatment plans. Okay, so here are some common reasons why someone might be right to refer to a cancer genetic counselor. So kind of just starting around from the left-hand side. So two or more members on the same side of the family have similar types of cancer. The presence of very rare cancer within a family, like a male breast cancer, also perhaps ovarian or pancreatic cancer, also being very rare cancers within a family. A single person within a family has more than one cancer type, like having both colon or uterine cancer, or perhaps both breast and ovarian cancer within one's lifetime. Um, Maybe more than one cancer in a set of siblings within a generation. Um, Perhaps the family is, a member of a certain population, like Ashkenazi Jewish, Dutch, or Icelandic, known to carry certain gene mutations that kind of travel more frequently within certain populations. Um, Perhaps cancer in kind of paired organs. So, like a woman having a bilateral breast cancer, for example, or an individual with bilateral kidney cancer, for example. Those might be reasons for referral. Um, Cancer at unusually young age. For example, someone with colon cancer in a 20-year-old. Another example, breast cancer in a 35-year-old, 40-year-old. And then cancer in two or more generations. And the middle image there, that kind of spotted black and white picture, that's a pedigree. That's kind of how we draw out a family tree to kind of denote who has cancer, who does not within a family, what types of cancer, ages, things like that. So again, common cancer genetic referral indications here. So, how a patient may prepare for a cancer genetic counseling session. So, they might want to write down certain questions that they have for the cancer genetic counselor, of course, to go through during the consultation. It's really helpful if patients gather as much information as they can about their family histories, their family medical history, with, of course, importance on the cancer within the family, who's had cancer, who hasn't, what types of cancer folks have had in the family, ages of diagnosis. Um, they might want to consider having a family member or a friend with them during the visit. Sometimes for some folks, having more eyes and ears during the session is better, sometimes not. That might be a consideration. It is informative if someone has had a cancer or a genetic test already within a family, if folks can collect copies or medical records related to the cancer in the family, or especially if someone has had genetic testing within a family already, if there's a known familial mutation in a cancer predisposition gene, having a copy of that report so that the genetic counselor then knows what the specific gene and mutation is. That's always helpful beforehand, or to provide at that first consultation. And then some patients may choose to also discuss with their insurance about the coverage of the genetic counseling session itself, and or the possible coverage of genetic testing. Sometimes that isn't fully understood until the genetic counseling session, until the family history has been gone through and kind of parsed through, meeting certain insurance criteria. But it may be something that the patient wants to look into before a genetic counseling session, certainly. Whoop, sorry about that. Okay, and then so for the genetic counseling visit, so typically a cancer genetic counseling visit is usually 1 to 2 visits, and of course that can vary between if the patient ends up pursuing genetic testing or not. Typically, when genetic counseling or genetic testing is pursued, typically then it's a 2-visit. If genetic testing is not elected, then it may just be a single visit for that patient or that family. And then so typically kind of how the session flows. So kind of information gathering, which we'll go through here, evaluating risk for cancer, kind of education piece, and obtaining informed consent, and then The specimen collection, again, if that patient does decide to pursue genetic testing, there's the actual, testing itself performed by a genetic testing lab, and then again, the kind of that second visit if genetic testing is pursued of follow-up and or the result disclosure. So overall, genetic counseling session is can be different than a typical doctor's visit. It might vary in length. Cancer genetic counseling visits might range between 30 minutes to even an hour. But I would say 30 minutes, maybe 20, 30 minutes is more kind of average of a typical initial genetic counseling visit to kind of, again, go through family history, gather all this information, and then talk about the genetic test itself, benefits, risks, limitations, all those kinds of things. So again, it's most helpful if patients are well prepared before the visit, maybe collect medical records from family members, collect the family medical history and cancer history, and that can certainly help just throughout that first visit. Okay. So then during the genetic counseling visit, so gathering information really is just a review, pretty comprehensive review of the patient's personal medical history and then their family history. Again, here's this image of a pedigree or kind of a family tree. So how genetic counselors delineate between who's who in the family, what's what, right? What kind of cancers exist in the family or not, ages at diagnosis. You'll see the squares here are male assigned at birth, and then the circles here are female assigned at birth. The shaded, so the blue in this case, the shaded folks are folks that have had cancer, so affected, and then the non-shaded are folks that are unaffected thus far by cancer. So that's typically how we transcribe that kind of information. Okay, so then the next portion of a genetic counseling visit typically involves evaluating that patient's risk, education, and then again, informed consent. So genetic counselors will determine the risk of that patient developing cancer. So kind of what their general lifetime risk for cancer may be. Is it close to general population? Is it perhaps elevated based on what we're seeing in the family history or that patient's personal history? There are some type of statistical risk models that genetic counselors use to kind of help with that. And then of course, we'll determine if genetic testing is warranted for that individual. If so, what specific genetic changes should be tested for. And again, who might be the best person in the family to consider genetic testing first and who's most informative. Typically, that is someone that's had a history of cancer themselves, so an affected person, whether they've had, have cancer currently or have had cancer in the past. And if there's multiple folks, let's say with the same type of cancer within the family, let's say multiple folks with breast cancer, for example, within a family, the best person to test or the most informative typically is that person that's been diagnosed at the youngest or the earliest age. So just some things to keep in mind that sometimes, while that genetic counseling visit is important and informative, that person might not be the best person to start testing within a family. Okay, so then the next kind of portion is just general, education. So informing folks of, kind of some of those topics we've covered earlier about hereditary cancer and again, who is best to test and why. And then informed consent. So discussing the risks, benefits, costs, limitations, types of results with this type of hereditary cancer genetic testing, the impact of test results. So this might be, both, short-term, long-term impact of genetic test results in terms of cancer screening and surveillance. Should that result be positive? Should that result be negative? Kind of painting different scenarios. And then also perhaps the psychosocial impact of genetic test results as well. And then again, test selection. So what particular genes should be, included on that test that are of importance based on the patient's personal and or family history. So then if a patient elects to pursue genetic testing, next comes the specimen collection and then the actual laboratory testing. So typical samples for hereditary cancer genetic testing either involve blood, saliva, so a spit test, or a buccal test, so a cheek swab. And they might have their sample collected at, physically at a hospital and or clinic. There are options for kind of mailing kits out to patients these days, particularly with the saliva and or buccal options. So patients can collect their sample at home and mail it back to the genetic testing lab. And then there are certain special circumstances as well. If a patient may have a certain, personal history of maybe a transplant of some kind, or a history of a hematologic malignancy, that might present special kind of circumstances of what sample type may be appropriate for them. But again, in most cases, blood or saliva is what most folks pursue. Then so the testing is that sample is sent to and completed at a genetic testing laboratory. There's a handful of accredited laboratories around the country that perform this particular type of hereditary cancer genetic testing, and typically there's a 2 to 3 week turnaround, and then comes follow-up. So again, typically this is another visit. It might be planned or scheduled, or it may be just kind of whenever those results roll in, and when the genetic counselor kind of slots a time to call that patient, they'll call and review. But typically that's something that's kind of worked out beforehand during that initial conversation of kind of a plan for follow-up. So the genetic counselor will share the result, or will follow up with the patient otherwise, either by phone, video, or in person. And there are typically 3 types of genetic results that might be found on a hereditary cancer genetic test. So a negative, a positive, or a variant of uncertain significance. A positive means that a certain gene mutation or some type of alteration was found that is known to be causative of producing an increased risk for certain cancers or tumors over the lifetime. Alternatively, a negative result just means that there's no significant variations of any type found on the test, and therefore no genetic kind of risk identified within that person. There may still be, in that case, certain caveats. So maybe other folks in the family would still be good candidates to test at that point. But a negative, again, means that we didn't find a genetic reason for that person, that individual. A variant of uncertain significance is kind of a unique result to genetics and genetic testing. It really just means that the lab found a particular variation or difference within that person's DNA, that there might just be not enough conclusive details at this point in time in order to make a conclusive classification. So perhaps the lab has just never seen that variation before, and therefore they just don't have enough evidence at this point in time in order to make a classification. Or perhaps they have seen that variation before, and maybe they still have conflicting or just inconclusive information at this point in time. So variations of uncertain significance or unknown significance, you'll see there on the screen, kind of synonymous there. They are very normal, very common types of genetic findings, simply because we're all human. We've all got differences, down to the level of our DNA, and it's just what makes us different and unique from each other. Most variations of unknown or uncertain significance are benign, just waiting to be called benign at some point in the future. So the laboratories continue to collect data and evidence about variations of unknown or uncertain significance over time, with the intent to try and reclassify them in the future. So it may be that if and when they produce an updated result, either conclusively negative or conclusively positive, then that result will be issued back to the genetic counselor and or the patient, and the genetic counselor would typically follow up with the patient at that point in time with that updated information. Okay, and with that, I hope that's given you a good summary of what to expect during a genetic counseling session. So I'll be turning it over to Katie Stoll to discuss other special considerations during a genetic counseling appointment. Thank you.
Now, I would like to speak a little bit about some different considerations that come up when considering test selection for patients. There are many factors to consider when deciding whether or not genetic testing is indicated for patients, and if so, what testing is the best option. For example, we may be considering who in the family is the best person to begin testing, which is the specific best test to order for the given clinical situation, what specific testing lab should we be ordering the testing from? And how do we go about placing this order in the first place? I think the most key first question is really determining who in the family is the best person to begin the testing. Sometimes that's the patient presenting to you, but sometimes it might be a family member that would be best to start this process. Generally, we try to start testing in a family with the person who's most likely to carry a genetic mutation. And that's usually a person who's been affected with cancer and a cancer that's related to the genetic concern in the family. So for instance, if we're talking about concern related to the BRCA1 and BRCA2 genes, we may be looking at that family history to consider who's had a diagnosis of breast cancer, ovarian cancer, prostate cancer. We may be looking at people in the family who have had the diagnosis at younger ages, or maybe a rare diagnosis. For example, if there's a male with breast cancer, that person may be a good person in the family to begin this process with. If a genetic mutation is found in a family member, this gives us a really specific starting point to think about testing for unaffected relatives. This would allow for a single site test that could be very definitive in giving a yes or no answer for other family members to say, do you share this cancer risk or do you not? And this is actually usually the most economical way to go about testing in terms of resources, because we know that these single site tests can be much less expensive and costly than the broader test or even single gene tests. On the other side of that, if you start testing with a family member who's most likely to carry a genetic mutation, somebody who's had an early onset cancer, for example, and their testing does not show a genetic mutation, that's a good indicator that it's much less likely that genetic testing is going to be helpful for other family members in the family who have not had cancer. Without knowing a specific genetic mutation in the family, we really consider results, negative results in other family members to be somewhat uninformative. We don't know what genetic risks might be causing cancer in the family, and so a negative test doesn't really reassure us that we haven't found whatever it is that's going on in that family. So if I'm referred a patient, for example, because their mother has been recently diagnosed with ovarian cancer and has a personal history of breast cancer, I may encourage my patient to defer testing until we find out if her mother has had any genetic testing, and if so, what those results are. If her mother has testing and a genetic mutation is identified, then this gives us a very clear place to look for a genetic mutation for the patient, and allows for that yes or no answer. On the other hand, if the mother has genetic testing, this mother who's had breast and ovarian cancer and no genetic mutation is found, that doesn't necessarily mean that there's no higher risk for my patient, but it means that genetic testing might not do much to help us decipher that risk. And we may really be making our recommendations for screening for our patient based on the family history and other factors rather than the genetic testing results. Another consideration is that it can be very helpful to obtain the test report from the affected family member, the person who's had a genetic mutation, or even if genetic testing's been done in the family, to review reports for family members when the testing's been negative or when there's been a variant of uncertain significance. Having that specific information can be very helpful context for interpreting the results for a patient who you may be seeing. And it can also really decrease the likelihood of misunderstandings that we frequently see in this space. It's not uncommon for a patient to come for genetic counseling reporting that their family member has a BRCA1 mutation. And upon reviewing records for that family member, we may recognize that they had estrogen receptor positive breast cancer and in fact never had genetic testing for a germline mutation. Or there may be confusion around somatic testing that identifies genetic variants that people mistakenly understand to be inherited. There's also often misunderstandings around variants of uncertain significance, where people may have a misinterpretation that a variant of uncertain significance is a definitive, clear genetic risk, when in fact, it may likely not have anything to do with the cancer in the family. So we always try to confirm if genetic testing has been done in the family. If we're able to review those results, that can be very helpful in guiding those next steps. There's generally 3 different types of or categories of testing that I would consider as far as different types of genetic testing for hereditary cancer. So single site testing is referring to that known pathogenic variant that is in the family. So if somebody in the family's had genetic testing, a pathogenic variant's been identified, then we can provide testing for other family members and give them a true positive or true negative result with regards to that specific variant. Sometimes there may be a very specific concern related to a very specific genetic inherited risk, and we might want to be looking at that one specific gene, or maybe 2 or a few different genes. And currently there are many different types of genetic panels that look at multiple genes. Unfortunately, there's really no standardization among the labs in terms of the testing options, so the genes included on different panels offered by different labs can vary tremendously. It's really important if you're concerned about a specific genetic susceptibility that you ensure that that gene is included on whatever test that you're ordering. I wanted to share a case example just to illustrate some of the complexities with regards to family history analysis and testing, especially when a genetic variant might be known in a family. This specific case, this is a patient that came for genetic counseling, actually presented to their primary care provider after their mother was diagnosed with a BRCA1 mutation, a pathogenic variant in the BRCA1 gene, following a diagnosis of breast cancer. Upon the patient requesting genetic testing from their primary care provider, they went online to their electronic health record, and through that system ordered the first BRCA1 BRCA1 test that came up, which was a comprehensive analysis of both the BRCA1 and BRCA2 gene. So in this case, it could have been helpful to just review that mother's test report to make sure indeed that it was a BRCA1 mutation that the patient's mother had, and also to allow for a more targeted single site testing if that were the case. In this case, the patient had this more comprehensive BRCA1 and BRCA2 gene testing, and indeed did come back testing positive for a BRCA1 pathogenic variant, which was presumed to probably be the same as that one that had been found in her mother. At this point, the primary care provider refers the patient on for genetic counseling to get more information. And through that process, the genetic counselor takes a more extensive family history, at which time the patient reports that her father has a history of some genetic polyposis syndrome. The genetic counselor requested to review more information about this history with the patient's father and learned that indeed the father had a diagnosis of familial adenomatous polyposis due to a pathogenic variant in the APC gene. And that specific mutation was already known, and that allowed for definitive informative testing for that APC gene mutation for our patient here, in which she tested also positive for the APC gene variant. This was really important for this patient because, in fact, she was already behind kind of schedule in terms of recommended follow-up for the familial adenomatous polyposis. We know that these precancerous adenomatous polyps can come up very early at a very young age in people with FAP, and we recommend starting screening colonoscopies at a very young age. So fortuitous that this, was discovered kind of through more further analysis of the patient's family history, but just as some take-home points, it can be very helpful and important for context to review those family history reports, and also to consider not just the family history from that initial report when somebody comes in saying that they have a family history of cancer on one side of the family. We really need to look at both sides of the family because there can be concerns on both sides. So in terms of some specific challenges with regards to genetic testing, not all tests are easily orderable through your institution's record in many places. So oftentimes through an institution, there may be a contracted lab that's connected in through the electronic health record, and it makes it very easy to order some certain types of genetic tests. But the full spectrum of what's available and what may be best for the patient may not be easy to find or order within that system. Oftentimes, we might be ordering testing under a miscellaneous test code. And sometimes we do end up sending testing to a lab that might not be the best in that individual situation, just for the ease of sample collection. But I really do encourage people to just recognize that there is tremendous variability in the different tests that are out there, and what might be the easiest test to order may not be the best one that meets the patient's specific needs, or that's the best use of healthcare resources in terms of more targeted to that patient's family and personal history. For many reasons, the person that may be the best in the family to have begun testing may not be available to do so. In that case, you may be left with consideration for genetic testing for somebody who's never had cancer but has a family history of cancer. In this case, it is important to consider current guidelines with regards to recommendations for genetic testing. Insurance often have their own criteria that point back to these guidelines, such as those from the National Comprehensive Cancer Network, or NCCN, or the United States Preventative Services Task Force, or the American Society of Clinical Oncology. There are many guidelines that help determine when somebody meets the clinical criteria, that there's a higher chance for an inherited genetic risk, and genetic testing is considered indicated. These guidelines change frequently and can be a lot to keep up with, so just encouraging you all to reach out to a genetic counselor or somebody who's in the space requesting this type of testing frequently. If there are people available to help with those types of questions. And with that, I'll turn it over to Heidi to talk a little bit more about the specifics of insurance coverage and genetic testing. And thank you.
Thank you, Katie, for the introduction and for inviting me to contribute to this project. And thank you to participants for taking the time to access this webinar. I hope you're enjoying these sessions and that they prove helpful to your practice and your patients. I will be taking the next 10 minutes to review the current landscape of genetic testing costs, insurance coverage, and challenges that genetic counselors all navigate and are familiar with in the process of cancer genetic evaluation. I do not have any conflicts of interest to disclose. The experiences and opinions that I'll be sharing during this presentation are my own and not representing my employer. To set the stage, it's relevant to look back to the earlier days of cancer genetic testing and how that has shaped perceptions and concerns about the cost burden of genetic testing. Historically, genetic testing was quite expensive, and insurance criteria for coverage were very exclusive. Genetic counselors dedicated a large amount of our time to addressing cost and insurance concerns, preparing insurance pre-authorizations, and submitting insurance appeals. In my personal experience, I used to feel that my role had become primarily that of a financial counselor and advocate who also knew some things about genetics. Ultimately, despite our best efforts, many patients were unable to access this valuable information due to cost, and many more patients were deterred from even seeking genetic services in the first place due to concern about potential costs. Today, I'm happy to say that genetic testing access is much improved. More expansive testing criteria, changes in the testing technology, increased laboratory and test choices, and more patient-friendly laboratory billing policies have broken down many of these barriers to genetic testing. That said, each individual situation may still have its own nuances and challenges that must be considered in the test ordering process. Let's start with insurance and billing. As with any healthcare provider or service, laboratory choices are often influenced by insurance due to contracts and the difference between in-network versus out-of-network benefits. Some insurance companies base coverage decisions on defined criteria, and many also require pre-authorization for genetic testing. Many of the genetics laboratories now have dedicated billing and pre-authorization specialists who take on the task of submitting and following up on these insurance requests. This has allowed genetic counselors to spend more time focused on our specialty of choice. However, Clear and detailed clinical documentation of the patient and family history and the medical necessity of genetic testing remains key in supporting this process. Notably, some laboratories do not offer direct insurance billing, but require either institutional billing or direct patient payment. It's important to know these billing policies prior to ordering a test so that there is not a surprise bill to the patient or the ordering facility. Some labs also offer no-cost testing options, such as industry-sponsored testing programs. Patients often ask upfront what testing will cost them. Even if testing is approved by insurance, patients may still face out-of-pocket responsibility related to unmet deductible, copay, and/or coinsurance. Some testing laboratories will work directly with patients to help manage these costs, either with payment plans or reduced out-of-pocket costs based on insurance status or household income. Some laboratories also offer direct self-pay options in lieu of insurance billing, with patient costs as low as a couple $100s. Although the patient cost is not zero in all cases, this is a significant improvement from the thousands of dollars that patients may have faced in the past. Some insurance companies explicitly require genetic counseling by a trained professional not employed by the testing laboratory as part of the authorization process for genetic testing. This slide includes an example from Cigna's genetic testing recommendation form. I want to also highlight some specific nuances for patients with Medicare. As quoted from the Medicare criteria for BRCA1 and BRCA2 genetic testing, Medicare is a defined benefit program and requires that testing is only performed on patients with signs and symptoms of disease. Testing of unaffected individuals or family members is not a covered Medicare service. In short, Medicare does cover genetic testing within defined criteria in the setting of a cancer diagnosis, but does not cover genetic testing for the purposes of pre-symptomatic risk assessment. However, this policy should not be a complete deterrent to recommending genetic testing for your patients with Medicare. As I mentioned earlier, many of the testing laboratories do offer relatively low-cost self-pay options so that patients can still have testing even in the absence of insurance coverage. I will also note here that CMS does not yet recognize or reimburse genetic counselors for our services, despite outlining the benefits of genetic counseling throughout the published Medicare policy on genetic testing. Currently, in order to receive Medicare reimbursement, genetic counseling in these cases requires direct physician supervision, which is another barrier to accessing these specialized services. Advocating for CMS recognition is an ongoing effort in our profession, with the Access to Genetic Counselor Services Act first introduced in 2021 and reintroduced last summer. I use this platform unashamedly to ask for your support for this initiative so that genetic counselors can in turn better support your patients and their families. Some additional challenges and concerns to be aware of. Many insurance policies consider genetic testing as a once-in-a-lifetime benefit. In theory, this seems reasonable considering that germline gene testing is However, testing technology and sensitivity changes over time, new genes are discovered, and patient and family medical histories may also change. So sometimes we need to offer updated or additional genetic testing later on. Genetic testing for hereditary breast cancer offers a good illustration of this concept. When commercial BRCA1 and BRCA2 gene testing was first introduced in 1996, this involved sequencing of these two genes. In 2002, 5 specific large rearrangements or partial gene deletions within BRCA1 were added to the platform. In 2006, comprehensive rearrangement testing of both genes was developed and offered as a separate test, but only for patients meeting more strict criteria. In 2013, full sequencing and comprehensive large rearrangement analysis of both genes became available on all BRCA test orders. And at present, and for the last several years, it is standard to offer testing on a multi-gene panel. Specifically, NCCN recommends that breast cancer genetic testing includes 7 genes, including BRCA1 and 2, plus 5 other high-risk breast cancer genes. Fortunately, many payers do recognize the need for updated and expanded testing, but this is a nuance that needs to be considered in each case and test order. Also, referencing the preceding lecture, Katie Stoll presented the complexities of test selection and when to consider focused testing versus broader testing. Some patients may come for genetic evaluation with a known mutation already identified in the family, but on reviewing the family history, we may uncover concern for other possible genetic risks that warrant testing more broadly. If this is not recognized and captured in the initial test order, it may be much more difficult to secure insurance approval and coverage for additional testing in the future, as this may be perceived as redundant by the payer. Finally, patients often still come with concerns about possible genetic discrimination. The Genetic Information Non-Discrimination Act of 2008 offers protection against genetic discrimination in health insurance and employment, but it is important to note that some exceptions do exist. For example, these protections do not extend to the military. Further, this law does not prohibit use of genetic information for decisions related to life insurance, long-term care, or disability insurance. In summary, access to genetic testing has greatly expanded over the last several years, allowing many more patients to use this information in their healthcare and decisions. However, the process of genetic test selection, ordering, and interpretation remains complex, and insurance and financial considerations are a relevant part of these decisions. Genetic counselors are trained and experienced to help you and your patients navigate not only the health implications of genetic testing, but also the financial and logistical considerations that are inherent to the genetic testing process. Thank you.
Hi, thanks so much for tuning into this CME on genetic testing and shared decision-making. I'm Kobe Witten, and I'll be doing this with my colleague, Carrie Trout, who's a patient navigator. So just to begin, what is shared decision-making? It's been in the research for a while now, and it really is just this process where the healthcare provider works together with the patient to reach decisions about what's going to go forward with respect to care. And the underpinning of it is dual. One is patient autonomy. We know that every patient coming in for treatment is an individual. They have their own values, their own beliefs, and their own feelings about risks and benefits of treatments. And it also, a critical component is informed consent. So understanding what the advantages and disadvantages of all evidence-based treatment options are. It differs from just sole informed consent in that I'm not, as the patient, only basing my decision on what the literature shows, what the research shows, with respect to cancer, the NCCN guidelines show, but also what my own values and beliefs are about the way I want to live my life, quality of life, what is tolerable for me and what is not. And of course, the healthcare provider's perspective may differ from what the patient believes, what they value, their opinions, and also their expectations about outcomes. So I like to include this. This dates me, but this is Marcus Welby. He was on TV decades ago. His colleague was James Brolin, the younger doctor. And Dr. Welby was a lovely man. He was this benevolent, compassionate provider. And he didn't really need to have any shared decision-making conversations with patients. He knew what was best and proceeded to do so. Things are different now. Some patients, I think, actually would like more of a Marcus Welby model. And that's why it's really important to know who your patient is and what they want. But there's obvious reasons for shared decision-making, ethical. We really do want to support patient autonomy. The legal issues around true informed consent and patients' understanding. And of course, that can be complicated. I sometimes say when people hear the word cancer, that it's like parents or adults in a Charlie Brown video. All you hear after the word cancer from the provider may be wah, 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 wah. So you're being asked to make critical decisions at a time when cognitively and emotionally you may feel overwhelmed. There's also policy reasons. Currently, many healthcare organizations really include shared decision making in terms of what their expectations are. So more reasons on why. I think that time, which we'll discuss a little bit later, which I know is very limited right now, but shared decision making really does demand and allow time to discuss these critical decisions and for the patient to share information about who they are and talk with the provider and really make sure that they understand what are the benefits, what are the harms, what are the possible outcomes, knowing that there are no guarantees. It also allows people to make decisions about their treatment and healthcare that really are in line with their values and what their needs are. It can get interesting sometimes when the patient's values and needs may not correlate well with their family members. And that's where these discussions really are also very crucial. Also, my own personal choice as a patient with respect to what degree I want to engage in shared decision making. There's literature on minimizers and maximizers in terms of how much intervention you want. I once had a friend, he was 95 and he was a patient of a healthcare system that would not give him a colonoscopy. And he really wanted one. And after years of advocating for himself, he finally got one and it was negative. And the provider said, "You're good to go. It's clear." And my friend said, "Are you not going to be here in 10 years? So clearly he was a maximizer. There are other people who are minimizers. They really don't want a lot of intervention and they probably don't frequent the healthcare provider very often to begin with. So that's just one dimension of differences among people. There's more research on shared decision making in the literature that when people engage in shared decision making with their healthcare team, they end up having less regret down the line about the decisions they've made. They have more satisfaction in the healthcare they've received. They're more likely to adhere to treatment recommendations, lifestyle recommendations. So of course, that's all very positive. So it's a three-step process. First, just clarifying with the patient that there is a choice often in how to proceed, and that you're really inviting the patient to be actively engaged in what's going to go forward with respect to their care. As best as possible, providing unbiased, up-to-date, and evidence-based information, and then really encouraging and supporting deliberation, again, taking into account those values, beliefs, needs, in conjunction with the clinician's guidance. I've had patients say to me that, I'm afraid the pendulum has swung so far the other way from the paternal, here's what you need to do model, to the provider saying, well, here's the options, what do you want to do? And I had one patient say to the provider, well, I didn't go to medical school for 93 years and residency and training, so maybe you could help me based on what the literature shows. So definitely we need that evidence-based information, not just values, beliefs, as part of this discussion. So with respect to genetic counseling for cancer, there are a number of special considerations. We really do encourage it to happen as quickly as possible because of the possible impact on treatment decisions. For example, a woman recently diagnosed with ovarian cancer with an underlying BRCA1 mutation can be treated with PARP inhibitors, which shows increased survival over more conventional treatment. So we'd want to know that up front. Other family members are affected, possible conflict. There was an article in the New York Times several years ago that this one woman's decision to get genetic testing really caused a lot of issues in the family because her sister did not want testing and did not want to know the information. So you really, I can't stress enough the benefit of a genetic counselor who's trained not only in the science, but in counseling and talking to people and their loved ones and working or at least identifying and supporting people when these issues come up. What are the downstream ramifications? Well, tests that we do today that are deemed maybe unimportant or inconclusive testing may in the future be linked to increased risk of disease. So it's not just what we're doing today, it's that downstream ramifications. And I get this a lot. There's confusion now among patients between genomic testing of their tumor with respect to specific mutations and treatment recommendations versus hereditary risk. And what we're talking about today is the hereditary risk. So important to clarify that. Also, it's just, I see it all the time, the saturation of marketing, telling people to send in their saliva and they can tell you your health, your health risk. And we've had patients who have this done and they're negative, and it turns out the full appropriate panel wasn't done, and they actually have a mutation. So the testing is often incomplete. There's little to no counseling, and there's absolutely no shared decision making. Before someone embarks on having genetic testing, there should be a discussion, not just send off your cells in the mail. Certainly for women, younger women, and there are fertility issues and decisions about preservation, and just a discussion around that is critically important, especially for that the regret later on. So other considerations, depending on what we find in the testing, there may be increased surveillance and all the emotions that go with that. I do a lot of work on fear of recurrence and also just fear, the Damocles sword syndrome, we call it, that after you've been diagnosed with cancer, or maybe even after you find out you're higher risk for cancer, you're feeling like this sword's over your head. How do I live with this anxiety and this uncertainty? You may make treatment decisions like a risk-reducing mastectomy or oophorectomy. You may want some assistance with reproduction if the fertility is compromised because of what's going on. And then really back to that uncertain results and maybe secondary findings that you weren't even aware of. So that may open a Pandora's box of additional recommendations, testing, and follow-up. And all that needs to be discussed up front. There are barriers for sure, and I don't have to tell you as healthcare providers what's going on right now in our healthcare system, but time is a precious jewel, and there's very little of it. I have patients who are diagnosed in 2002, 2004, and they've now had a recurrence all this time later. And they describe being grateful for the increased treatments available, but that their experience with the healthcare system is really significantly worse, that it's just so busy and time is just really very limited. So to have these discussions may not be possible. Also, the science is really rapidly evolving, and that affects guidelines and recommendations. It's very challenging for providers to stay up to date. Our healthcare system is so fragmented, and just the industrialization of it, focusing on efficiency, profit, etc., has really exacerbated burnout among our providers. And also, as I noted, our patients feel it. They feel the frustration, fatigue. They have great compassion for the providers, but they're scared. And, you know, they want this holistic team approach, and it often doesn't happen right now. Of course, COVID-19 exacerbated all of that, the in-person encounters. Perhaps your loved one couldn't be in the room with you when these critical decisions were being made, so even more challenging. And all of the specialists are, I just picture these individual silos, and sometimes there are not bridges between the silos. And there are so many multiple factors important, I think, especially early on when given system constraints. Perhaps patients can't see a medical oncologist immediately. They go right to a surgeon. And so these decisions that really should be a team approach that should be discussed, hopefully in a cancer conference with the whole team there, that may not happen. There are tools, there are great online tools to help patients and providers with these decisions. So just offering a couple of them here. One is from Ottawa Hospital Research. They're all free, and I think they're really helpful. And then another one is HealthWise, very helpful with respect to breast cancer and what should I do right now in terms of what kind of surgery should I have, what kind of reconstruction, is that something I want, what am I looking at? So I'm going to hand it over to our breast navigator now, Carrie, but I guess the one thing I want to emphasize is that we understand the constraints on your time, on your expertise, on your ability to know all of this. And that's why I think the referral to a genetic counselor, honestly, is more critical now more than ever. Thanks very much. I'll hand it over to Carrie.
Hi, my name is Carrie Trout. I'm a breast patient navigator. The role of a breast navigator is to help expedite appointments for patients, coordinate appointments, be there for questions, support, resources. My role as a navigator is to be a part of the patient's care team early on in a diagnosis to help expedite these appointments. I would like to share how genetic testing could have made the difference in the lives of two sisters. Sister A was diagnosed with breast cancer at the age of 46. Because she did not have a family history of breast cancer, her medical team did not feel that genetic counseling was important and that she really wasn't at risk for any genetic mutations. So the patient did not meet with genetic counseling, and she proceeded with her treatment plan of going for surgery, followed by radiation and then endocrine therapy. A year later, her sister, Sister B, was diagnosed with a breast cancer diagnosis at the age of 46. NCCN guidelines recommend that anybody under the age of 50 gets genetic testing for breast cancer if they're diagnosed under the age of 50. So Sister B, in my conversation with her, talking about the role of genetic counseling and genetic testing, decided to proceed with getting genetic testing. She was diagnosed with the BRCA2 mutation. So with her diagnosis of the BRCA2 mutation, her sister, Sister A, then proceeded with genetic testing, and she came back with a BRCA2 mutation as well. And then a year later, Sister A was diagnosed with a second breast cancer. So had these patients had genetic counseling and genetic testing at the onset of Sister A's diagnosis, her second breast cancer could have potentially been prevented, and her sister's breast cancer diagnosis could have also been prevented. And in this situation, there was a third sister who has opted to not get genetic testing at this time. Genetic testing plays an important role in the treatment plan and treatment decisions that a patient makes with a breast cancer diagnosis. That's why it's important for patients to get in to see genetic counseling early on in their diagnosis. My role as a navigator is to help facilitate these referrals and these appointments, and having primary care providers make those referrals expedites a patient's care. I think sometimes primary care often feels that it's the role of the oncologist to make these referrals for genetic counseling. But in today's medical maze, there are often delays in patient care. So if we can get the genetic testing done early on in the patient's diagnosis, that allows a faster turnaround time for those results, and patients are able to make decisions about their care without delay.
Thank you, Carrie, for sharing your experience as a breast cancer patient navigator. Thank you, Dr. Witten, for this presentation on shared decision-making. And thank you, Alina and Heidi, for sharing what we can currently expect from a genetic counseling appointment. I would just like to end by highlighting what a complicated and rapidly evolving space genetic testing is for hereditary cancer at this time. Just over a decade ago, we were only able to offer genetic testing for a small handful of genes for very specific conditions. Testing was often very expensive and often not covered by insurance. This meant that testing was often cost prohibitive and not accessible to patients, even when we knew it could tremendously benefit their care. Things have changed so much in recent years with regards to genetic testing, including that it is much more accessible with better coverage by insurance and more testing options. However, there are new challenges to consider. There's no standardization in the testing that's available, and there's many factors that need to be considered when determining what testing option is best for an individual patient. Of course, an essential factor in determining what is best for an individual patient is really understanding that patient's individual situation and their preferences. That's one reason that shared decision-making for genetic testing is so crucial. For example, unlike many other tests in medicine, genetic testing has implications beyond the individual patient, with importance for family members as well. And when patients don't understand the implications of this up front, it can add tremendous burden and a heaviness when it comes to thinking about sharing this information with family members. Shared understanding of the information that comes from genetic testing also has important implications on adherence to guidelines and treatment decisions regarding a genetic risk. Genetic counselors can be helpful partners in this process and have the time to work through many of these questions that come up when a patient is making decisions around genetic testing. And we hope that this presentation has given you some information that could help give your patients guidance when it comes to considerations for genetic counseling and genetic testing. I want to sincerely thank all of our speakers for volunteering their time and expertise as part of the CME activity. And I want to thank you for viewing this session, Cancer Genetic Counseling Guidance for You and Your Patients. Speaker bios, as well as links for other sessions in this 5-part series, can be found on the Washington Medical Commission website. You will also find on the website a link to the webinar evaluation. As you will remember, completion of this evaluation is required in order to receive CME credit. Thanks again for your participation.